right, I think we'll go ahead and get started. Greetings from Seattle. On behalf of the Northwest Mental Health Technology Transfer Center, we welcome you to today's webinar, Psychological First Aid, Increasing Resiliency During COVID-19, with Doctors Michelle Bedard-Gilligan and Emily Dworkin. We're grateful so many of you could join us to learn more about this important topic, and it's certainly one we think is particularly relevant during these challenging times. We look forward to sharing information, tips, and guidance, and to having an exchange of information with all of you today. My name is Maria Monroe DeVita, and I am the co-director of the Northwest MHTTC. Let's start with a little introduction to the Northwest MHTTC. The MHTTC network is a nationwide network that is supported by the Substance Abuse and Mental Health Services Administration, with the purpose of disseminating and implementing evidence-based practices for mental health disorders within the behavioral health workforce. The Northwest MHTTC is based at the University of Washington in the Department of Psychiatry and Behavioral Sciences. We provide training and technical assistance in evidence-based practices to Region 10, which includes the states of Alaska, Idaho, Oregon, and Washington. Broadly, our goals at the Northwest MHTTC are to ensure availability and delivery of free, publicly available training and technical assistance to Region 10 providers, heighten awareness, knowledge, and skills of the workforce addressing the needs of individuals with mental illness, accelerate adoption and implementation of mental health-related EBPs across Region 10, and to foster alliances among culturally diverse mental health providers, policymakers, family members, and individuals receiving services. Next, we want to say a little something about language. It is our intention to always be mindful of using language that promotes recovery and culturally appropriate terminology. We encourage everyone to use and champion first-person language, which emphasizes the individual, not the condition or diagnosis. Person-first language is a way to demonstrate respect for a person's dignity and worth. It is consistent with recovery-oriented practices and promotes service environments that foster respect, human dignity, and hope. And so now, just to get us started today, we want to make sure to launch a couple of polls just so that we know who is quote unquote in the room. So please tell us about your role. We have a number of different choices here, about 9 of them, and if none of them fit your particular role, you can click on Other. It looks like so far we've got a number of you from education, schools, school-based organizations, behavioral health clinicians and therapists, case managers and outreach workers. So we'll kind of allow just a couple more seconds to get all of our votes in. Almost 70% or so of you have launched your response here. And then we'll share our results here in a minute so we know who's here. Okay, and it looks like most of our participants are behavioral health clinicians and therapists, and then about 19% case managers and outreach workers, 14% education, school or school-based organizations. So great, we've got a broad range of you. And then in our next poll, if you want to click out, you just have to close the poll in front of you so that you can see the next slide. Now tell us in the second poll about your typical work setting. And we say typical because we know many of you are at home right now, but where do you typically work? And again, we've got about 10 or so options here. It looks like we've got a number of you again that are from behavioral health clinics or treatment programs, also educational settings, kind of aligning with who your various roles and that. So a little over half of you have voted, and we're almost complete with your surveying here. So it looks like most of you, about 23%, are from behavioral health clinics or treatment programs, and another almost quarter from educational settings, and then outpatient healthcare centers is the next percentage. But again, a broad range, including 5% of you from peer-run programs and who are peer specialists. So great, that's very helpful to us and to kind of know where the questions are coming from. And so if you just want to click on that top little X there to close it out so you can see the rest of the slides. So now for the important part, I want to introduce our wonderful presenters, Michelle Bedard-Gilligan and Emily Dworkin. Dr. Michelle Bedard-Gilligan is an associate professor in the University of Washington Department of Psychiatry and Behavioral Sciences and the co-director of the Trauma Recovery Innovations Program. Her program of research focuses on understanding response to traumatic events with a focus on alcohol and substance misuse, and on building and testing interventions designed to promote recovery following trauma exposure. She is also a licensed clinical psychologist and maintains an active clinical practice. Dr. Emily R. Dworkin is a licensed clinical psychologist and an acting assistant professor at the University of Washington School of Medicine. Her research focuses on trauma recovery with a focus on identifying strategies to promote resilience and understanding the role of social relationships in post-trauma outcomes. So now I will turn things over to our presenters and welcome Michelle and Emily. Thanks for being here today.
Hi there, sorry about that. I had to unmute. So it looks like I now have control of the slides. Excellent. Thank you so much. I appreciate the introduction, and I really appreciate being here. I'm excited to talk with you all today about psychological first aid, which is an approach to increasing resiliency during and following stressful times. So things like mass disasters, community crises, and certainly something like what we're all going through right now with COVID-19. Let's see here. So first I want to acknowledge the organizations and the individuals who have been really influential and helpful in sort of building the work that we're going to present today. So it's important to know that the information we're going to be presenting on psychological first aid is information that has been developed and adapted, first starting with the World Health Organization, who has put out a free open access guide to implementing psychological first aid, as well as the National Child Traumatic Stress Network and the National Center for PTSD, which has also put out a PFA guide, which are all publicly accessible. In addition, we want to thank our colleague, Dr. Deborah Kaysen, who is now down at Stanford University, who was helpful in developing these materials. And then finally, we want to thank the following people for supporting the work that we've been doing and trying to promote psychological first aid as an approach to helping individuals cope with COVID-19. This includes the University of Washington Department of Psychiatry and Behavioral Sciences, as well as the University of Washington COVID-19 Mental Health Working Group, which is composed of psychiatrists, psychologists, social workers who have been putting our heads together about the best ways that we can help the community in these trying times, as well as, of course, I want to thank the faculty and staff at the Northwest Mental Health Technology and Transfer Center, and as well as SAMHSA for inviting us in and having us here to present today. So the webinar today, we are going to cover psychological first aid. So basically what we're going to try to do is talk about the why, what, when, who, and how of psychological first aid, which is also referred to as PFA. So we're going to spend a little bit of time talking about why it is that we think resilience training following something like a pandemic is really important. We're going to talk about the foundations of PFA, what it is, and then also what it isn't. So what are some of the limits or some of the ways in which PFA is not applied or is not useful. We're going to talk about when to deliver PFA, so when it is most useful for individuals who are trying to cope in the midst of a disaster or a pandemic, who is most likely to benefit and who should be delivering PFA. And then we're going to spend a large chunk of time talking about how. So how is it that we deliver PFA? What are some strategies that comprise PFA, how best to implement them, and then as well as tips for sort of things we've learned along the way about what is kind of most useful when trying to do PFA with someone. So like I said, we're going to start with the why. So we're going to start with why we think PFA is so important and why we see a need to build resilience during times like COVID-19. And I want to first start by talking about resilience. So we think of resilience as the process of adapting well, even in the face of really significant adversity or significant sources of stress. And so we think of it as that ability to keep moving forward despite the really significant challenges that we might face. And it's really important to note that we know that resilience is actually extremely ordinary and it's extremely common. It is the most likely outcome that people have following even really significant traumatic events and stressors. So we don't consider it an extraordinary process. Instead, we as humans are somewhat programmed to be resilient. We are programmed to withstand even the most significant stressors. And so we really expect resilience in a large proportion of the community. And it's important to remember that when we're talking about resilience, we're not talking about the absence of difficulty or distress. So the definition of being resilient does not mean that you are not affected by the stressor or the traumatic event. It just means that you continue to function, you continue to move forward, and you find ways to adapt in order to kind of continue to live life and keep going despite the significant adversity. It's also important to remember that it's not a trait. So we don't think of resilience as something you have or don't. So we don't really characterize there's some people who are resilient and some people who aren't. Instead, we really think of it as something that is learned and acquired. Resilience takes effort. It's something that takes a lot of work to both sort of build up and to continue to admit during a stressful or a traumatic time. And so it's not something that just happens or doesn't happen. It's something that we have to learn and really work at in order to kind of keep moving forward during adversity and stress. And it's also important to remember that we don't think of resilience as a one-size-fits-all thing. So resilience is going to look a lot of different ways, depending on the individual and their specific circumstances. So we can think of resilience as this ability to sort of keep going, to persevere, to keep moving, to keep working towards goals, and to keep living life, even if it looks vastly changed or different because of a stressor or a crisis that's going on. And that's going to really vary from person to person. There is also no one path to resilience. So it isn't this idea that we should be following a straight line when we're coping with traumatic events or really stressful experiences. Instead, we think of resilience as messy. We think of it as something where, you know, you're going to have good days, you're going to have bad days. Things are going to sometimes feel really hard, and then sometimes they're going to feel much easier. You know, it's up and down and back and forth, and it doesn't necessarily look like some kind of linear process of coping. It just doesn't work that way, especially in the middle of a really challenging time like we're in now. And I think one of the things about the COVID-19 crisis that has become most evident to most of us is that this is not a short-term situation. This is a long-term situation, a long-term chronic stressor that we're going to be dealing with for the foreseeable future. And it's a stressor that we're going to be having to continue to be resilient in the face of sort of all the circumstances that it's throwing at us. And it's going to be a chronic thing, and it's going to be a chronic stressor that's punctuated by these periods of acute stress going up. So we're going to have periods, months, weeks, days, depending on what your role is in COVID-19, that acute stress is going to go through the roof and things are going to get really, really challenging. And then we're going to have times where we settle back into sort of a baseline level of increased chronic stress from where we were 3 months ago. And that pattern's going to continue for a while. And so we really need to think about resilience as something that sometimes we're going to need to put more effort into than others. And we're really going to have to continue to work at sort of continuing to move forward despite the state of things or what we're predicting will be the state of things for the foreseeable future. And like I said, most of us are in a good spot to be resilient. Most of us we know from the data after lots of other large scale events, that most of us are going to continue to cope and continue to be resilient in the face of this stressor. But we also know that for some of us, it's going to be more challenging than others. And we know that there are certain risk factors that make people more vulnerable to being less resilient than others, or to struggle more with being resilient. And some of these things are kind of general risk factors like the severity of the event. So we know that the closer individuals are to a stressful or traumatic event, the more directly impacted by it they are, the harder it's going to be. They're going to have to work harder to do that process of continuing to move forward and cope on a daily basis. So with COVID-19, that might look like individuals who are kind of on the front lines of the crisis, healthcare workers, grocery store workers, delivery drivers who are consistently having to kind of put themselves in situations that feel scary over and over and sort of are being more kind of exposed to the crisis itself than many of the rest of us. And then of course, obviously, if you develop an active infection or someone really close to you develops an infection, we would consider that a more severe experience of the COVID-19 crisis as well. And then things that are happening in the background too. So things like life stress and social support. So we know that individuals who are dealing with increased levels of life stress, so those with a lot of competing demands, for example, those who are caretaking for others, those kinds of stressors are going to make it more difficult to be resilient because they add to the burden and they add to sort of they take away from the coping reserves that we all have. And then social support as well. So we know that social support is extremely protective, and we also know that for individuals who have limited access to social support, that it's going to be harder to be resilient. So we know that individuals who are dealing with either limited contact with people that they're close with, or they're people that they're close to are somehow limited in their ability to provide support, are going to be sort of, it's going to be harder for them to cope adaptively. And we also know that in addition to those situational risk factors, there'll be pre-existing risk factors as well. Previous experiences, so individuals who've had past trauma exposure, particularly if they're continuing to struggle with symptoms from that trauma exposure, individuals with pre-existing mental health problems, or individuals who've had relied on maladaptive coping strategies in the past. And so, you know, for example, they've been using alcohol or substances to cope or something along those lines. And so these are sort of individual risk factors that can put people at risk for having a more difficult time dealing with a stressor like COVID-19. And so you can think about some of these risk factors, both the situational and then the pre-existing, and you can think about them you know, as things that we look for in individuals to think about who might need the most support or the most help in being resilient. And we can target our efforts towards individuals who have some of these risk factors. Because we know that COVID-19 is going to have, or very likely will have effects, negative effects on many of us. And so we can think about the effects that we're already seeing from COVID-19 in the kind of still early stages of this crisis. So things like higher workload and increased stress for many of us. People who work in the healthcare industry or in healthcare at all are dealing with the loss of coworkers at times, and the loss of patients, anxiety about coworkers, patients, and families, feeling distress about decisions, and difficulties prioritizing and allocating care to themselves and other people. These are all things that are COVID-19 is affecting and is making more challenging for people. And it's important to remember these things because we know that what happens during the acute and chronic stress phases matters a lot for who recovers. So I started by saying that most of us were resilient, and that is very true. But we also know that what we do during the stressor makes a big difference for who is going to be resilient and who is going to be less resilient. And so the amount of kind of support and resources and coping that somebody exhibits during and immediately after a crisis predicts resilience. And so there are things that we can do to help people be more resilient and keep moving forward. And so that brings us to PFA. So PFA is an approach that's really designed to promote resilience. It's designed to be implemented with those we think are particularly vulnerable in order to increase and bring out their kind of existing effective coping strategies and really increase their resilience. And so PFA, psychological first aid, is what we would call a humane and supportive response to someone's suffering. So it's an acute intervention, meaning it's meant to be done in the midst of a traumatic experience, so either while that traumatic event is still ongoing or immediately after. And its goal is really to reduce that initial distress and to set the person on a path for adaptive coping with the distress that might follow. We call PFA evidence-informed. There are no direct randomized clinical trials that have been done showing direct efficacy of PFA, and yet it is built on strategies that have a wealth of evidence behind them, so mainly CBT strategies. So it's evidence-informed in that the strategies that are inherent in PFA are based on things that have a lot of existing evidence. The goals of PFA are to increase the sense of safety, connection, calmness, and hope for an individual. And so it's really about helping to stabilize them, connect them with resources, and help them to feel hopeful and calm about their ability to cope with the crisis moving forward. And there's other goals inherent in PFA are to increase access to social, physical, and emotional support. So help the person connect with things that are going to be helpful in taking a resilient path. And then also to increase their self-efficacy. So to help them feel confident and hopeful about their ability to cope on their own and to survive the stressor and keep moving forward. So their ability that they can do this and they can tolerate this is a big, building up that sense is a big piece of PFA. PFA does differ from traditional treatment. So this gets into what PFA is not. So PFA is not therapy. We don't actually think of it as a therapy approach to treat psychopathology. It is not treating psychopathology. PFA is an approach to building resilience. And so it is a resilience skill building program. It is not therapy designed for mental health problems or mental illness. It does not look like a standard therapy setting or structure. So many of us, depending on what kind of care we normally provide, this might look really different. It doesn't necessarily, it certainly doesn't look like things like insight-oriented therapy or psychodynamic or analytic therapy. It's much more sort of a structured skill-based approach. It's not the time or place to really dive into interpretations or exposure or to talk about past learning experiences. PFA is very present and centered in that it's really dealing with the acute crisis at hand and the effects of that acute crisis. And then importantly, if you have experience and you've heard of something called psychological debriefing, we like to take a moment to acknowledge that it is not that. So psychological debriefing is an approach that has a less than stellar reputation. It was unhelpful for a number of people when it was initially rolled out. The reasons that we think psychological debriefing was unhelpful had to do with the mode of delivery. So it was delivered in a group format where individuals were sort of mandated to talk in depth about the traumatic event that they had just survived. And we found that this actually could be unhelpful. And psychological debriefing, psychological first aid really takes the stance of doing the exact opposite of that. So psychological first aid is really about people seeking support, seeking care. It's completely optional. It's very client-centered in that they are empowered to make decisions about what would be helpful for them in terms of building up their resiliency. And it does not focus on sort of reliving details of the traumatic event itself. In terms of some of the general PFA guidelines, PFA is best done when we're in a framework of an organized response system. So when we're working as part of a team, so having supports and individuals around, and when we talk that can support you in your work with the client who's seeking PFA is really helpful. And when we talk more about the strategies inherent in PFA, you'll see why, because a lot of it is about connecting individuals to resources and supports. And so having a framework for being able to do that is a really useful piece. Other general guidelines around PFA include maintaining confidentiality. So although it is not therapy, it is designed to encourage individuals to share and to talk about their experiences and their reactions to those experiences. And so confidentiality is a big piece. There's an emphasis on respecting individuals' rights to make their own well-informed decisions. So it's often about giving people choices in the midst of a crisis and helping them to make the most informed choice they can, as well as being culturally sensitive and aware of how these events are going to impact us all differently, particularly depending on what kind of culture and context we're coming from. PFA really encourages the providers to remain within the scope of their expertise, role, and training. So there will be times where what is being presented is not actually appropriate for PFA, either because of the acuity of the reaction or the severity, in which case then it's the PFA's provider to help connect them with something that's more appropriate. And then because PFA is an approach that's really developed to be implemented during wide-scale mass disasters, there is an assumption that I hear I have a glare. Sorry about that. Was it hard to see the slides? Hopefully that fixed it. Please pop me a message if it didn't fix it. So because it's this approach to mass disasters, there's a emphasis on encouraging people who are delivering PFA to practice good self-care. So there's an assumption that we're all being affected by whatever mass disaster PFA is being delivered for. And so being able to practice good self-care, being aware of your own physical and emotional reactions is really key. And I think another really important point about what PFA is that it is an approach to approach to how to structure our responses to acute crisis reactions. And so PFA is often used as a standalone intervention. So it's something that people come in and they do with somebody during their acute reaction, and they may only meet that person one time, or they may only see that person one time. And so, for example, at University of Washington, we're using PFA in that way. So we are using PFA for our COVID support line, where we have healthcare workers who can call the support line and be connected to a provider, such as MLA or someone else at UW, who can provide a PFA session to them. And that may be the only time that they interact with that person. We're just there to give the PFA and to help them kind of figure out an adaptive way to cope with the acute stressor. And that's often the way PFA is provided. But PFA really is just a structure to put around how do we respond to really acute distress in the midst of a crisis. And so PFA can also be integrated into a larger treatment plan. So if you are working with someone doing something else with them, but they start to have really acute reactions because of the COVID-19 experience. So they're in some way exposed to something that has to do with COVID-19 and are experiencing a great deal of distress or acute reactions around that. You can use PFA to structure a couple of sessions to respond to that acute distress and hopefully help them with that, help them cope with, put them on the kind of coping pathway for COVID-19 specifically, and then move back into sort of your greater treatment plan and what you were doing with them. Some of the core themes around PFA. So how do we do this? How do we put people on this resilient path? So it's really about providing practical care and support that isn't intrusive. So like I said, it's really about meeting someone where they're at and then letting them make decisions about what they think would be helpful. And see, these are some of the core themes that we're going to be talking about in more detail, but it's really about being calm, compassionate, and respectful in how we communicate. Listening for people who want to share, encouraging that when it's what the person wants, but not forcing it. Giving accurate information. So in the midst of crises, things are changing constantly. And so being as careful as we can to give accurate and direct information to help people regain a sense of control about what they can and can't do during this crisis. Helping people cope in healthy ways. So teaching more adaptive coping strategies, connecting people with services and social supports when needed. As I mentioned earlier, we know that social support can be extremely protective, and so helping to connect people with services and social supports that'll be useful to them. And then finally, teaching ways to manage strong emotions. So sometimes there's an emphasis on teaching short-term strategies to help individuals manage strong emotions that might come up in response to the stressor. PFA is meant to be delivered during a mass disaster or in the immediate aftermath. So it is meant to help prioritize and respond to needs in times of crisis. And so it's a framework for that. And so it really is meant to be done while an individual is sort of in the thick of things. And that's because it really is tailored to these acute reactions that occur that we think are, in many ways very much normal, where they're expected. We expect some amount of acute distress. And so PFA is really meant to respond to that acute distress while it's happening, and then hopefully set individuals on a resilient path. And if what we see is that individuals are still suffering many months down the road after the acute stressor has passed, then we're actually looking at different approaches, different therapy approaches or different intervention approaches other than PFA. So PFA is really meant for that acute phase. And as I mentioned earlier, PFA does not necessarily require a mental health specialist for delivery. And we think it can be helpful to a range of individuals. So providers don't necessarily need to have a mental health background in order to do PFA. And they do need to have some amount of training in PFA, and they do need to have met their own needs first in terms of feeling stable with their own distress. But they don't necessarily have to be therapists. They don't necessarily have to have some kind of specialized training. A lot of people can learn to do PFA. The strategies are really pretty straightforward, and they're meant to be straightforward because they're meant to be delivered in a time of acute crisis when individuals are really struggling with the amount of information that they have and the amount of reactions that they have. Recipients of PFA, so we do target PFA towards those who are interested in support and stabilization, and not everyone will be. So some people will feel like they're coping fine on their own, and those people should generally be left alone. This is for individuals who are asking for something, who are thinking that they need a little help or a little extra support, but because their current coping strategies aren't working for them. In addition, we often target, as I mentioned earlier, PFA towards those we think are at higher risk for developing negative outcomes. So individuals who are either in close proximity to the crisis or exhibit some of the other risk factors that we talked about, because those are the folks that we think are most likely to not be resilient on their own, who need a little more training in order to kind of cope and cope adaptively. And so those are often the people that we see as most appropriate for PFA. And as I mentioned earlier, there may be times where individuals need more advanced mental health support than we can give and more than PFA can provide. And so it's important with PFA to know your limits and to know when and where to refer. And we're happy to talk more about individual situations like that in the Q&A. But basically it's around knowing what PFA is for. It's meant for this acute distress reactions. It's meant to be delivered in just 1 or 2 sessions. And if individuals are really needing more around the current crisis, then really thinking through how we can connect them to those resources so they can get what they need. And at that, I'm going to turn it over to Emily, who is going to take over.
Okay, so I think I'm still waiting for access to the slides. Okay. Thank you. So I'm going to be talking about the how of PFA, meaning the actual strategies that you'd use to implement PFA with somebody that you're in contact with during this crisis. So PFA is a toolkit of different actions, and we call these 8 core actions. They're not necessarily sequential, so you don't have to do them in order. They're flexible and in fact should be tailored to the needs of the person in front of you. They don't have to be done in the same way for every single person. And they're really based on a given person's specific needs and concerns, and in particular what a person is saying they want rather than our assumptions about what we might think that they want. And that's part of the emphasis of PFA on being really culturally competent, not making assumptions, and doing a good assessment to inform the strategies that we use. So the 8 core actions are contact and engagement. So making the first contact and establishing safety and security. And I should say I will go through these in greater detail, but the bird's eye view of them is what I'm going to discuss now. Safety and comfort, so making sure kind of main needs are met, stabilizing emotional responses, gathering information, doing some practical assistance, linking people to social supports, getting them information on coping, and then linking them to services by making referrals. So first, I'm going to talk about the first 2 core actions, which are contact and engagement and supporting people's safety and comfort. And the goal at this stage is really to help people feel comfortable with their contact with you and build initial rapport, let them know that you understand where they're coming from, and support and enhance their emotional and physical safety. And in the context of the current COVID crisis, this may be about assessing and expecting concerns about one's safety, concerns about the well-being of oneself, but also loved ones. If you're working in a healthcare setting, people may be concerned about their patients. And if you're working in any setting with essential workers, likely people are going to be expressing concerns about their coworkers as well. So getting a sense of what people's pressing needs are and what they're saying would be most helpful to address together. As we go through the how section of this talk, you'll see some pro tips, which are just sort of our advice about how to implement these skills. And when thinking about how to support people and attending to their basic needs, we can think about first meeting needs for safety and comfort above all else. And then after that, other basic needs like food and shelter and medical needs. And what we want to emphasize here is that it's not your job to have to meet all these needs yourself. So this is about what Michelle said about staying within your role and within what you can do, and not overpromising, but helping people get connected with services that can meet these needs, or problem solving the barriers that they're experiencing in accessing these services and mobilizing resources for them. This can also include providing options to them. So not just giving them one referral, but knowing the range of different alternatives that they may have to meet their basic needs, and helping them consider the pros and cons of different approaches. PFA also draws on your good clinical communication skills, which I know that you all have, but just to emphasize, one important piece of this is to be calm and to show understanding. So I think one of the challenges with addressing people's distress in the context of COVID is that we're all experiencing distress, and it can be hard to kind of manage your own emotional reactions, which is why it's important to have your own needs met before delivering this intervention. But we want to try to have a calming presence and show understanding in a way that helps people feel a little bit more safe and secure, and like we understand them and respect where they're coming from, and that we'll do our best to help them meet their needs. Second, we really want to focus on what they want to tell us and how we can be of help, rather than, again, what we're assuming would be most helpful to them, or trying to get them to talk about something in particular. So really meeting them where they are. Third, it's really important to, as appropriate, allow some silence to give people the space that they may need to share if they should wish to share. So for people that want to share, talking about one's distress, talking about the experiences you're having, is really helpful for emotional processing. So to the degree that people want to do that, we want to facilitate it, but it can be counterproductive if we're forcing them to disclose when they don't want to, or they're not ready to. Fourth, we want to use simple and concrete terms without jargon. So we want to use accessible language that is not, sometimes I know that I can get into like academic speak, and so I have to sort of check the language I'm using to make sure that it's accessible to everybody that I might be interfacing with. And then finally, we really want to try to identify and acknowledge people's strengths that are coming to us. So we want to acknowledge what they've already done to take care of themselves and other people, in part because this helps people identify the strengths that they can then build on to help themselves. And also because I think it can be hard to recognize your own strengths when you're feeling like nothing is going right. So acknowledging those strengths, acknowledging what they've already done to cope can be really powerful in that regard. For many people, people will come to you with strong emotional reactions. And one of the takeaways that we want to convey to you is the importance of sitting with these strong emotional responses. So it can be really normal as people in a helping profession to want to kind of take away those strong emotions in the moment. And even after, being in this field for 15 years, when people come to me and are really upset, all that I want to do, and initially my knee-jerk reaction is to just take their pain away. But the problem is we can't take their pain away, right? We can't change the fact that this is a really difficult situation and is really genuinely stressful. And it's important to feel those emotions rather than trying to make them change those emotions. Because when you try to make them change those emotions rather than sitting with them, that can communicate something sort of invalidating, that it's not, that they can be kind of gotten over maybe more quickly than is appropriate. So instead, what we want to do is sit with emotions and give people a safe space to experience any emotions that they're feeling, and let them tell you what they feel and need. Again, this is about remaining calm, trying to control your emotions and not rushing things, but kind of in the spirit of helping people be able to express their emotions should they wish. And then just to reemphasize this, you can't take their pain away, and it's not your job to take their pain away. What your job is helping them express their pain and helping them troubleshoot ways that they can cope adaptively moving forward. In responding to strong emotions, one of the helpful strategies for sitting with the emotion rather than trying to change them is validating emotions. So recognizing what emotions they're feeling and kind of commenting on them and summarizing, their perspective and why they're feeling those emotions. And in doing that, reminding them that there's no right or wrong way to feel. So some people might be feeling really numb and some people might be having really intense reactions. And we would actually consider both of those completely normal emotional reactions to what's going on. And validating that for people can be really powerful, because often people feel like the emotions that they're experiencing are themselves a problem. And we want to remind people that their emotions are healthy and normal, and a normal part of processing a really abnormal experience. We want to acknowledge to people that they'll probably experience a range of up and down emotions for a while. As Michelle said, recovery from this is not linear. We don't expect emotional recovery to be as well. So they will likely experience other periods of distress in the future, and it doesn't mean that they're getting worse or that there's anything wrong with them. For yourself, it's important to expect a wide variety of reactions to this and not judge what people's reaction happens to be. And then finally, help support parents and caregivers about how they can talk to their kids in validating ways about the crisis. One of the things that we want to highlight that's specific to COVID is that part of the challenge here is that a lot of our typical processes and rituals around grief are not possible at the moment. And that can be a source of distress for many people that's important to validate. So it's important to acknowledge that what people may be doing to cope with mourning in particular may be a deviation from their typical rituals or from what they would have wanted or what their loved one might have wanted. And what we can do instead is to help them identify achievable things that they can do to mourn and recognize death if that's what they're coping with. And then find ways to engage virtual supports and comfort even from a distance. So next I'd like to talk about stabilization, which is when somebody comes to you with an emotional reaction so intense that it's getting in the way of their functioning. So the goal with stabilization is to help calm and orient survivors of a crisis who may be emotionally overwhelmed or disoriented. And what I want to emphasize here, consistent with what I was just saying about the importance of sitting with emotions, is that not all individuals are going to need stabilization. The people that need stabilization are those people whose reactions are so intense and persistent that it's impacting their ability to function, or it's causing a safety risk to themselves or somebody else. So one of the stabilization strategies that we suggest is grounding, and we, as I'll go over at the end of the talk, have created some infographics about grounding that includes a decision aid for when you would use grounding. We do not recommend grounding as a go-to long-term coping skill. This is a sort of one-time skill to be used in a crisis situation for people that are so intensely emotional that it's getting in the way of something they absolutely need to do, threatening their safety or preventing them from coping in healthy ways. So if you decide that grounding is indicated for somebody, again, as sort of a short-term and not long-term coping strategy, what you would have them do is sit comfortably and breathe slowly and deeply, trying to fill up their belly. And sometimes you can tell people to put their hands on their belly to encourage that. Then you can have them name 5 non-distressing things that they can see around them, and then pause and breathe. Name 5 non-distressing sounds that they can hear and pause and breathe. And then finally, name 5 non-distressing things that they can feel, like their clothes on their skin, or the temperature of the room on their skin. And then again, pause and breathe. So next I'll talk about information gathering and practical assistance. And what we want to do here is help people that are experiencing a lot of kind of issues that are going on at the same time, help them identify and prioritize their needs and concerns, and then develop a plan for whatever they've decided is their kind of top concern. So in doing this, remember, this is not a one-size-fits-all strategy, and we have to use our active listening skills to be able to do a good assessment and to collaboratively prioritize people's needs. And also in doing this, it's important to know what your local resources are. And if you're not quite sure what they are, know who to ask to find out or where to go to find out. In Michelle and I's work doing support calls, we have one particular person on staff at UW who's just a wealth of knowledge about referrals. And so she's that person for us. And so just keeping that person in mind for yourself is important in doing this stage of PFA. So once you've triaged people's needs and identified the most pressing need, then what you want to do next is these problem-solving steps for making a plan. So again, you've assessed and prioritized, and then you select the most pressing, controllable issue to address. And the issue being controllable is important here, because if it's not in somebody's control, it doesn't make a ton of sense to brainstorm possible solutions and go through the stages of making a plan. But I think one of the challenges, again, with COVID is that a lot of the issues that are coming up for us are ones that aren't actually within our control. And so using different strategies for those issues would be more appropriate. So what you want to have people do is brainstorm the possible solutions to the problem. And then for every solution they've brainstormed, consider the pros and cons, and then choose a solution based on those pros and cons. And then finally make an action plan for exactly what they'll do in the next days or weeks for carrying out that solution. Next, PFA emphasizes connection with social supports as a core action. And what we want to do here is help people establish brief and/or ongoing contacts with support people around them, including their family, their friends, and their community members. And one thing we want to emphasize is that I think it can be challenging during COVID to think about what social support is, because a lot of the normal ways that we get social support, like, going over to somebody's house or, giving somebody a ride somewhere, aren't quite as available right now. But there's actually a real diversity in ways that you can give and get social support. And there's some examples on here, but it includes things like being there when somebody needs you, giving somebody advice or information, getting on a Zoom call with somebody, or even just texting with somebody. So there's not just one way to think about social support, and helping people think about this range of options is important. Next core action is coping. So coping is a core action that emphasizes giving people information about normal reactions to stress, and then giving people information about practical ways that they can cope and reduce stress, and then promote their adaptive functioning. And I'm going to give some examples of some of the information you can give here, but I want to emphasize that any information you provide, any skills that you teach, should be tailored to what the person in front of you is saying that they want and need. So like I said, the first important part of this core action is giving people information about common reactions to stress and common reactions to this crisis in particular. So what we expect is that people will experience intrusive reactions. So they might have intrusive thoughts about COVID even after the immediate crisis has ended. They might have also intrusive thoughts or even nightmares about particular situations that have come up for them in the context of this crisis. Second, avoidance reactions are really normal. So attempts to kind of avoid reminders of what happened or distressing things. So removing yourself or protecting yourself from distress. It's a really normal urge to want to do this. And we would just consider it pathological if it didn't go away in the short term. Next, physical arousal and reactions. So this would be the body acting as if the immediate danger is still present. So things like people's heart beating fast, people hyperventilating, having a lot of physical complaints like headaches or dizziness or muscle aches. Grief is also a really common response, especially for people that have lost loved ones. And then finally, depressive symptoms. So things like sleep problems and fatigue, feelings of worthlessness or guilt, or even suicidality. So these are common reactions, but again, we don't expect everybody to experience all of these. And for people that are experiencing them, they're not a sign that something is wrong. When they don't go away right away would be when we would have more concerns, or when they don't go away after maybe a couple months. There's also some reactions that we expect to people that are quarantined, as most of us are right now, including feeling really exhausted or detached, anxious or irritable, having low mood, having trouble concentrating on things that they need to do, or feeling really indecisive, feeling reluctant to work, and even having insomnia. And I'm sure that these reactions are familiar to many of you who've been quarantined for a really long time. And so these are definitely reactions that you can validate in people who are coming to you in distress. So again, what we want to do here is normalize these reactions, emphasize that they're natural and expected and common, and then help people make a plan to manage when these reactions come up for them. And then emphasize that when we would want them to get more help is if these reactions continue for more than 2 months or get a lot worse in such a way that they're getting in the way of people's functioning. So the pro tip here that we want to draw on, because sometimes it can be hard to know, exactly what what is most appropriate for a given person that's coming to you in distress, is that the first step that you can take is helping people identify their existing coping strategies. So even asking them, what have you done in the past to cope when you've been upset or distressed, and how can we adapt that to this context? And then once you've gone through that assessment of their existing coping skills, you can help them identify potential new ways of coping, which could include things like, making sure you're taking regular breaks, journaling, scheduling pleasant activities, using relaxation. So maybe some things that they haven't tried yet that might be useful in this situation if their existing coping strategies aren't working. And when we think about making a plan for helping people cope, we think about this sort of like you'd think about having a balanced diet. So when we're teaching people good nutrition, we ask them to balance the foods on their plate with food from different groups. And we can think about the same thing in terms of activities. So what we want to help people do is think about a toolkit for different coping strategies that they can draw on when they're in crisis, rather than always having to rely on the same thing, which may or may not be equally helpful across all circumstances. Okay, so now what we would want to do once we've assessed some possible coping strategies is help people develop a coping plan. And a useful thing to help people do at this point is think about what their role is and what their values are. So what's important to them in terms of how they are at work? What's important to them in terms of their health, their family or friends, their religion or spirituality, their community service, or their hobbies? Because when people are making a coping plan that's oriented to what's important to them, they're a lot more willing to carry it out, and it's more likely to be kind of a good long-term strategy for them. So it's an important thing to think about when going through this process. For people that are having issues with sleep in particular, what we recommend is helping people establish a regular sleep schedule and limiting daytime naps. So I think part of why quarantine can be disruptive and working from home can be disruptive is people's sleep schedule is in many cases pretty disrupted. So people are going to bed at different times and waking up maybe at pretty variable times. So we want to help people get on a pretty regular sleep schedule and avoid napping during the daytime. We also want to help people reduce their use of alcohol if they're having trouble sleeping, as well as eliminating caffeine in the afternoon or evening. Regular exercise can also be helpful, and then relaxation before bedtime can be helpful. But I would say of the strategies on this page, the absolute most helpful one is establishing that regular sleep schedule and limiting daytime naps. And then next, for people that are coming to you with problematic substance use, what you can do is talk with them about the pros and cons of using substances to cope, and really kind of taking a stance of helping them explore both those positives and negatives rather than trying to kind of push them to see it as a negative thing. And then once they've kind of considered that, working with them to identify other alternatives for using substances to cope. So what other things can they do when they're feeling upset? You can also help them talk about what their goals are for use and any difficulties they run into in changing their substance use. And if people are experiencing really high levels of substance use, or you have concerns about their safety, that might be an appropriate time to refer for treatment if it's appropriate and it's desired by them. So again, this isn't a time when we're sort of pushing things on them, but we can make recommendations and referrals as indicated. Next, a thing that can be helpful to do for people that are coming to you with a lot of unhelpful thoughts is asking gentle and curious questions to help address those thoughts and the strong emotions that those thoughts might bring up. So this would include things like people coming to you, perhaps saying that it was their fault that somebody died, that they should have done more, that they're, maybe they're thinking, I'm a bad parent, or I'm bad at my job now. So these thoughts that I think, come up for a lot of people during coronavirus that aren't 100% true, and in most cases aren't even mostly true, but are bringing up a lot of intense negative emotions. When we ask gentle and curious questions about them, it can help people consider other ways of seeing the situation. So saying things like, I noticed that this is a thing that you're saying to yourself, and maybe we can talk a little bit about whether that's the only way to see this. So what would your kind of self say about the situation? What are other ways to look at the situation? One that I like also is, if a friend came to you in the same situation and was saying that they had this thought, what would you say to them? Would you agree that this thought is 100% true, and why not, if not? And then the final core action is linking people with other services. And this core action involves connecting people to resources or services to address their current needs. And this is on an as needed basis. So I would not recommend just sending people kind of a list of all possible services, and unless that's what they're saying that they want. What we instead want to do is help create a tailored list of referrals for a given person, or make tailored recommendations for the services or resources that they could access to meet their stated needs. And again, this requires knowing what's available and how to connect them to those services or who to ask. And I've emphasized this before in the assessment part, but we really want to collaborate with them to identify what they need. And at this point, you can offer to follow up and check in on how accessing those resources or services went. PFA is typically delivered in just one session, but it doesn't say that you necessarily can't have a follow-up session. And for some people that maybe are going to have to access things that are difficult to access, having a follow-up appointment where you check in on how it went to access that and help them troubleshoot barriers might be indicated. So that is the overview of the how of PFA. And what I want to emphasize at this point is, as Michelle said at the beginning, and as I've re-emphasized, it's really important to meet your own needs and be practicing good self-care to be able to be an effective support to others during this crisis. And although these are all skills that we can use to help other people, PFA is also a way that we can help ourselves. So thinking about the problem-solving steps, if you feel really overwhelmed by multiple issues that are coming up for you, or thinking about gentle and curious questions to ask yourself if you're having a lot of negative thoughts. So we do encourage applying these types of strategies as self-care as a way to help you be more effective in your role of supporting other people. So these slides will be emailed out, but I just want to call your attention to some specific resources and references. So we've included a link to a detailed online PFA training through the National Child Traumatic Stress Network. There's also a PFA skills training manual through the National Center for PTSD. And the National Center for PTSD has also made a PFA mobile app that you can download. And there's also an app called PTSD Coach. They've actually made a version specifically for COVID, which I believe is called COVID Coach, that you can access through the National Center's website or through the App Store. And if you are located at UW, on the psychiatry department website, there's some specific resources, including some resources that we've put together, including some of the ones that we're going to be passing along to you in terms of infographics and handouts. So I wanted to go over the specific infographics that we're going to be sharing with you. So this one is a general summary of what PFA is and some of the main themes. I know that Michelle kind of highlighted some of this earlier on. Oops. We've also, like I said, included a infographic about using grounding that includes a decision aid about when you'd want to use grounding, and then a how-to about practicing grounding. We have an infographic about how to help people cope in healthy ways that includes the steps of problem solving and some examples of what healthy coping is and is not. And then finally, we've included this thing that we consider to be our kind of, big compendium worksheet that includes a lot of the elements of the other worksheets, but also includes a outline for a session that you could do together over the phone or over a video call. Okay, so at this point, I think we're going to switch to questions and discussion.
So this is Michelle popped back on. Thanks, Emily. I've been sort of monitoring the question and answer as well as Emily's been talking. So we'll definitely get to some of the great questions that have been typed in. A few of the questions that have come in are about sharing materials. So Emily provided the link to the online PFA training. So for the person who asked about how to get training, it's free. It takes what, 8 hours, Emily? 6 hours?
I think it's 6 hours. 6
to 8 hour training. I think it also gives CE credits, but I might be wrong about that. I'm not 100% positive on that one, so don't quote me on that one, but it is completely free to access. One caveat to doing that training, I think there's a ton of really useful information in there. It's made really interactive, which I think is helpful. But the original designers of PFA did not necessarily have something like a pandemic in mind. And so it really is skewed more towards responding to victims of hurricanes and earthquakes and mass shootings and those kinds of disasters. PFA has been used both with SARS and Ebola, and it was used quite effectively with both of those. And so I think, we have a leg to stand on, and that it's very applicable to COVID. And at the same time, if you do the online training, you'll notice those differences. We also have a list of other PFA resources that are more general. So the WHO manual for PFA, there's a manual out of Ohio for PFA that we've found helpful when we've put together these materials. And so I'm going to pass that list on, if I haven't already, I can't remember, to Maria and Christina and everyone else to share with you, so that it just sort of puts all those resources in one place to spare you the Google search, basically, as well as we'll provide our slides of the recording of this webinar, I believe, and then all of those fabulous handouts, which Emily is way too modest to say that she designed, because she's our fantastic graphic designer. And I personally find them extremely helpful as sort of cheat sheet references. So all of that will be provided as well. I know the training does not have to be completed in one day. You can log in and out of the training online as many times as you want, and it saves your place and you just go back to it. So we do have some other questions. I want to say thank you also to everyone who has expressed thanks for the training and typed it into the chat. We really appreciate being here. And so we really appreciate your attention. We know that everybody has a lot of competing demands right now, and so we really appreciate you prioritizing this and giving us your attention for the last hour. We hope it's helpful. I think Emily and I have really gotten a lot of personal resilience out of this, to be honest, in terms of rolling this out in the community. We're all struggling to find meaning and purpose and many other things, and to use our skills as we can to help in some way. Like, we're all feeling it as a community. And so it's been, I think, a really helpful thing for myself to be able to do this. And I find when I do get to deliver it with people, it tends to be a mastery experience that feels good. It feels like I can help in some way. And that's a really great feeling for me as a provider. So if it's okay, I guess we can start with the questions, and Emily, you can see them as well, I think, in the Q&A. So we'll just start with the first one, which is PFA typically only delivered to individuals and not groups? So typically, yes. So typically the general format of PFA has been individual, although with COVID-19, people are playing with that. So I know that our colleague, Deborah Kaysen, that we thanked at the very beginning, is doing group PFA down at Stanford with healthcare providers, and I believe it's working quite well. I think the caution with PFA as a group is you have to find a way to sort of make sure PFA is tailored enough to the individual's needs. So, there's 8 core actions in PFA, but not everybody needs all 8 core actions, and most people don't. Most of the time, you're maybe only doing 2 or 3 core actions in a session. So you might be doing stabilization and coping, or you might be doing information gathering and support. And so you have to find a way in group that everybody gets what they need without getting sort of information overload. The other thing to stay away from in group, and this is what I was alluding to as psychological debriefing is too much processing of trauma details in a group setting. And so we do know that hearing other people's trauma details can actually be unhelpful. And so if you're trying to do PFA in a group, you just have to put some pretty strict bounds on it being skill. And if someone wants to really process the experience they had, then they need to do that in private with somebody as opposed to in the group setting. And so those are sort of the caveats. But I think that the skills themselves of PFA and the actions of PFA translate to a group setting pretty well for the most part. Emily, do you want to take the next one? Or?
Yeah, and I just briefly to add to that, I think the other thing about PFA in groups is that when other people are disclosing, there can be a lot of pressure on people to disclose or to discuss details of their trauma, even if they might not have otherwise wanted to. And that was part of what they found potentially unhelpful about psychological debriefing, is that people were disclosing things in a group setting when really that wasn't what they needed or wanted at the time. So making sure that you set it up to not be just a kind of processing about things that people are stressed about, but instead more skills oriented. The next question is, can PFA be useful for any type of personal crisis, or is it just for a mass crisis? And what I would say to that is that it's designed to be for a mass crisis as a way to kind of get a set of skills quickly to a large number of people that we know tend to be the kind of go-to skills. But it also just draws on general good coping strategies for crises. I think the thing that PFA has in mind is that this is sort of a major disaster that is still ongoing. Whereas, it depends on what the personal crisis is, but kind of as a long-term coping strategy, there might be other things that are more indicated. But in general, these are skills that are unlikely to hurt. And so if people are finding that they're useful, I don't see a reason why it would be necessarily counterindicated. And I don't know if you have anything to add to that, Michelle.
No, I think I totally agree. I mean, I think with just keeping in mind that it really is this acute phase where PFA is indicated. And so it's this acute immediate aftermath. And so if you're seeing someone who still has distress that's at a really impactful level, or symptoms at a really impactful level months after their exposure, then we're sort of really thinking of other approaches. So there's a lot of other approaches out there for, the later recovery phases, and then of course approaches for the full, when people develop what we might call psychopathology, like post-traumatic stress disorder or depression or something like that. And so, in that context, I think it does actually work. It would be applicable to a variety of stressful traumatic experiences. The only other thing I would say to that is that I do think the community aspect of mass trauma exposure, where PFA is designed to be, is really designed to fit, is an important one to consider. So one of the things that's inherent in these trauma experiences where they affect entire communities at once is a degree of support and normalization that doesn't always happen when people experience individual events. And so just being aware of that and making sure that, even more normalization and even more connections to support and that kind of thing than maybe is even typical in PFA might be really important. Because I do think like there's an element of, we see lower rates of pathology after these kinds of mass events than we do after things like interpersonal violence exposure, for example. And we think a big piece of that is that the community goes through it together. And so there's an element of not being alone and having support kind of all around you at a systemic level even, that can make it a little different. We're getting a couple more questions about the 8-hour PFA training. So the link for the 8-hour PFA training is on the last slide, which will be shared with you. I don't know how else to get it. I guess we could put it in the chat, but it's on the last slide, and I think the slides will be posted or uploaded pretty soon after this is over. And so the link is right there for you to do the 8-hour training. And that link, like I said, it's a free training, so it can be distributed to staff or anyone who would want to do it.
And it's also pretty easy to find online. I think when Michelle initially told me about it, I think I just Googled PFA online training, and I think it was the first result. And so that might be a way to find it as well. And I think somebody asked whether it has to be done in one day. And I don't think so. I think you can just kind of put it.
You can log out and go back as many times as you want. So you could do it 8 days in a row on your lunch hour if you wanted to. It also doesn't, the 8 hours is an estimate because it's interactive. It could take a little more or a little less depending on how much you interact with it.
Yeah, but that could be a good way to get your staff trained if that's what you're you're hoping to get done.
Any other questions? We're certainly happy to take other questions. I think we have just about 5 minutes left until we're going to turn it over to folks to do the closing.
Remember, you can raise your hand, and we can also do a verbal back and forth, so you don't have to put it into the Q&A. So that can feel a little bit easier to get your answers.
Thanks, Maria, for that. Appreciate that.
We have one more. Okay, any other tips for tailoring this method specifically for COVID? You know, I think one of the things that has come up for us as we've thought about how to adapt this, which was originally developed for disasters, to a pandemic situation, and we drew on the prior SARS epidemic and Ebola, is that the acute phase of this crisis is going to be kind of longer than normal. And so as long as the crisis is still going on, I think PFA is an appropriate thing to implement, and the transition to other longer term skills might come a little bit later than other things. And then I think, you know, when we're thinking about implementing coping skills, thinking about just thinking creatively about kind of ways that people can cope even without being able to kind of see their friends face to face, or kind of go out there in the world in the way that they normally would have done. And I think a plus side of learning about this right now is that I think, you know, a lot of us have developed some of those strategies to cope, you know, after having been quarantined for the last couple of months. But just sort of thinking creatively and thinking on your feet about how this applies to this particular situation is what I'd encourage.
Yeah, and I think the only thing I'd add is that because of the nature of COVID-19, it's one of those things where we don't know yet when how or when we're going to define over. And so, you know, there's this chronic nature of it, you know, and I think really emphasizing that with people, that these coping strategies or these social supports or whatever it is that they might put in place as a result of PFA, they might have to pull them out pretty regularly for the next couple years, right? Like, this is not a one and done necessarily kind of thing. And so really sort of prepping people for that notion that the idea behind PFA is to help them learn the strategies so they can continue to cope for as long as we're plagued with this, and continue to kind of use what they learn and feel like they can have the efficacy to do it. Whereas getting a couple other questions about the online training, I do believe you get a certificate of completion when you complete the online training. We also had at least one person in the chat who vouched for the online training, who said that they completed it and that it was really helpful. So that's great. And I agree, I think it's well done. I think it's useful. And then somebody asked about children as well. And in the, I believe in the training, there's, in the manual, there are adaptations for children. So it talks a little bit about how you would apply with children, and also how you would apply it to people who have children. So ways that you can use PFA to help people help their children get through the crisis as well. So there's different strategies and more specifics about that in both the manual and the online training. And then there's the question about how you become a trainer in PFA. And PFA is, because it's public access, because it's one of those things that's evidence informed and based on a number of things that sort of already existed. There is no sort of like credentialing process. There is no, it's not like that. It's not like an EMDR style program or a DBT style thing. And so the reality is, in terms of wanting to teach PFA, if you know, anybody can actually put the materials together and teach it, if that's something they want to do and they feel like they understand it and they've done enough of it to be an expert in it. There is no sort of control over that as far as I know. So there's unfortunately no place to go to sort of get training in how do I train PFA. And you know, Emily and I, because we are trauma researchers and trauma clinicians, have done, you know, we do trainings in all kinds of approaches for trauma recovery, from PTSD oriented approaches to social support building approaches, to community building approaches, to trauma informed care. And we do a lot of that stuff. And so PFA is sort of in our wheelhouse and is very similar to other things we do. But there is no sort of tight tightly controlled PFA program like we have for some of the other mental health stuff. I don't know, Emily, anything you'd add to that?
Yeah.
Any other questions? Okay, well, thank you, Val, very much. I mean, I think we can hand it back over to Maria because it's about time anyway. But we really appreciate everyone being here. We appreciate your interest in the topic. Thank you so much for your attention and all your great questions. And we really wish you all the best in terms of your own coping and helping those you see that are struggling.
Thank you, Michelle and Emily. We really appreciate it. Also, please keep in touch. You'll find more out about us and be able to register for additional resources like this and have other training opportunities by going to our website at www.mhttcnetwork.org/northwest. You can also sign up to receive our newsletter while you're there. Find us on social media or email us with any questions. We and others have free self-paced online courses at healthyknowledge.org, and we share resources and free training opportunities from across the MHTTC network and other training centers. So while we have our own areas of focus, that's the beauty of having this network across the US is that we can put you in touch with pretty much any training content that is out there right now with those other centers and their areas of expertise. And finally, just a to you all. First of all, thank you once again to our presenters, Michelle Bedard-Gilligan and Emily Dworkin. Thank you to everyone for taking the time to learn more about psychological first aid, and we hope to see you all again soon. Take care, be safe.